So maybe when we begin to ask these questions, we will not be looking back after 4 and 5 years and saying, what were we thinking when we voted? We should at least know before we get it. I shall leave my political words at that. Leave you to interpret and translate, but I think the point is very clear. I'll leave my comments on the theme to after I've listened to the professor. But I'm sure maybe are wondering what qualifies me to be the chairman of this occasion. I grew up seeing my father with Baba. I wouldn't call them friends because Baba was like an elder brother to him. And I once asked my father how they met. And of course, my father was in the foreign service, and in 1960, he was in the Prime Minister's office, the Prime Minister being the first foreign minister we had. But his memory was that they started getting close when Baba was administrator of the Western region, and his ADC then was Murtala Muhammad. So my father used to visit Murtala, and they got close to Baba. And there are a few anecdotes that show how close they were. My immediate younger sister, Zainab, was born in 1972 in Brussels when my father was ambassador. And Baba and Mama had visited father in Brussels. And he told Baba that she was due in about 2-3 weeks. The day Baba was leaving, he looked at her and said, I think Hajia is due. And I know she had a few weeks to go. And he said no. He changed his ticket. Basically said, I'll see another 2 days. And the next day she had my sister Zainab. I wish I'd brought her here. It was always, I brought her to see, my father got me to bring her to greet Baba so that she would see the father who effectively delivered her in Brussels. We were on the board of Merchant Banking Corporation together until my father passed before him. So we feel we are the same family. I feel part of this family. And he took me as a son, as did Mama. And we pray that, I'm happy to see that the foundation is going on. I'm happy to see my brothers all going on. And we pray that his vision for this country will come to fruition and that we'll be able to contribute in our own ways to the fulfillment of that vision. So like I said, on the theme, I would like to listen to the professor, and then if I need to make comments, I will. What is left for me now is to wish all of us a successful program, and to continue to pray for Baba and Mama and all our parents who've passed away, that Allah receive them in his paradise and give them and shower them with his mercy and everlasting light. Thank you very much.
Thank you very much, Royal Highness. And I would also like to remind you that on page 8 and 9, you will find a synopsis of our chairman today, which I think is very good reading, especially to date on some of his activities, where it continues to ensure that he's impacting the lives of the citizens of Kano and the country as chairman of Black Rhino Group, the portfolio company of Blackstone. We're involved in building a 120 megawatt solar plant in Kano, and of course, to be chairman of the Impact Capital Fund named Babangona Big Farm, which is dedicated to agricultural development. These are important things, challenges the nation faces, and of course, our chairman today is very keenly involved in all those activities. Another round of applause, please. The Honorable Minister of Health naturally was invited, and naturally he would have loved to have been present on this occasion. But Dr. Asage Nahiri is inevitably and unfortunately involved in state affairs that prevent him from coming to this occasion. It's not because the airfares are too expensive for the minister at the moment, but he has deputized someone who we had hoped would be here in his own capacity in any case. And he is also here as the Chief Medical Director of Lagos University Teaching Hospital, but he's also been asked to represent the Minister of Health, Professor Chris Body. I'm going to ask him to come and make a few remarks on behalf of the Honorable Minister of Health.
Thank you. Your Royal Highness, Mohammed Sanusi, the Seriki Kano, the chairman of the MAJEKODUNMI Foundation, Mr. Desmond MAJEKODUNMI, Dapo, and the entire MAJEKODUNMI clan, distinguished ladies and gentlemen. I'm here representing now the Honorable Minister of Health, Dr. Osake Hanire, who is unavoidably absent. He would have loved to be here. He told me he's also an in-law to the MAJEKODUNMIs, and he sends his kindest apologies. I don't know whether you married a lady from here, or so I don't know whether to prostrate or to receive. If I'm supposed to receive any prostration, I forgive it on his behalf. But he has asked me to say matters of state that have prevented him from being here. As we all know, the Federal Executive Council meeting holds on Wednesday mornings. Having observed all protocols, he sends his congratulations on today's auspicious occasion, the 10th anniversary of Papa's passing, and to also commend the foundation for the sterling steps and the solid foundation that's been laid in healthcare in Papa's name. I therefore commend your vision in doing all these legacy-focused programs on behalf of Nigeria. You are filling great gaps, and we must commend Papa, who was the Honorable Minister of Health between 1961 and 62. For us in Louth at the Lagos University Teaching Hospital, we always read the plaque with his name inscribed. He was instrumental. He moved that the then mainland hospital, specialist hospital, should be converted into the Lagos University Teaching Hospital 60 years ago. And we are always grateful to his name for that. I must also commend a rare phenomenon, something we seldom see in Nigeria. That is the transgenerational transfer of leadership and visionary skills from one. When many times you see somebody who's great, the offsprings fall flat. But the MAJEKODUNMI clan has continued to be at the vanguard of progress, visionary leadership, and the promotion of healthcare in Nigeria. That is good. The Honorable Minister says the Federal Ministry of Health will eagerly await the outcome of today's deliberations, so as in ways that they can inform policies at the ministry. The Yorubas, we often say something. They say, when a rich man dies, he will be remembered for up to 7 years. A poor man is forgotten after 6 months. But when you see somebody who has worthy children, they live forever. Papa lives forever in the heart of all of us. Thank you very much. I wish us the best for today and always. Thank you. God bless you.
Thank you very much, Professor Chris Body, Chief Medical Director of LUTH, representing the Honorable Minister of Health, Dr. Sage Henry. Your Royal Highness, distinguished ladies and gentlemen, the foundation doesn't run on its own, and apart from the Board of Directors of the foundation who continue to ensure that the ethos of the foundation is maintained, you of course have several other people working in the background on a continuous basis. And one of those is the Executive Director of the foundation, who is going to come, as she does every year, to bring us up to date on the activities of the foundation, which go very far beyond this annual lecture. Please welcome Mrs. Omobolaji Fati to come and make a few remarks and do a video presentation. Thank
you. Good morning, ladies and gentlemen. I humbly request that you permit me to say protocols. I'm honored by the opportunity to stand here again before everyone at another August event. This is 2022. We are all humbled by the gift of life after the onslaught of COVID-19. Today is especially auspicious because we're celebrating 10 years of Chief Dr. Moses ADEKOYEJO MAJEKODUNMI's passage to greater glory and the legacy he has left behind. By the way, I also fondly call him Papa, as most people do. Papa was a great man, both in his private life and in his professional life. A man worthy to be mentioned, even in the footprints of time. I would have been honored to have met the man myself. This same man set up the MAJEKODUNMI Foundation, and as the executive director of the foundation, I had the unwavering support of our outstanding members who are constantly redefining and upscaling the foundation to unmeasurable new heights. I don't want to take any more time, as I have a documentary for us to watch on the programs we've done over the years, and this program promises to fulfill a lot of our expectation. I'm going to leave you with a short video of some of the works we've undertaken. We'll take a few minutes to enjoy this film. And those who are interested in volunteering to work with us, or joining our hands together to build the foundation further, we can have a conversation after this event. Thank you all for taking the time out of your busy schedules to grace this occasion, and God bless you. Thank you.
Like, if you asked me 5 years ago, I would have told you that I don't think I'll be able to complete my medical education.
3 to 4 years now that I've been on scholarship has been very beneficial for me, because I come from a family that is not so well to do.
Nǹkan tí mi ò lérò pé ó lè ṣẹlẹ̀ ní 10 years this time, In 2012, practical operations and projects of Chief Dr. Moses ADEKOYEJO MAJEKODUNMI Foundation commenced. The foundation was set up by the late Chief Dr. Moses ADEKOYEJO MAJEKODUNMI, a pioneer obstetrician and gynecologist in Nigeria, with the aim of providing succor to the less privileged in the area of education and healthcare.
Well, the vision of the foundation, as laid down by the founder, which is my father, Dr. Moses ADEKOYEJO MAJEKODUNMI, is to give back to society, to his country, what he had got from the country and from the society. He's lived a very successful life as a very successful medical practitioner, and so he feels obliged to give back to society what he had got from society.
So the foundation is just the apex. I cannot count the number of members of the family that Uncle had helped. Scholarships, monetary giving, most importantly for the church.
During Chief Dr. Moses ADEKOYEJO MAJEKODUNMI's lifetime, he was a seasoned administrator, distinguished scholar, contributing to numerous charitable and philanthropic causes.
Papa educated many more children than his own and kept quiet about his philanthropy, but when he saw a need, he was in a position to help. He did so. This was especially true in the field of education. Education has always been important to my father, and as time went on, he began to talk about the education of girls. He would often say that if there were more women running the country, Nigeria would be better off.
I'll say with its foundation, which has two main thrusts, which is education and medicine. I remember once so in the interview, I asked him what is the most important thing in the country that we should need to do. And he said not long, he said education. So I think we recognize a fundamental thing that we need to look at, improve is education. So his foundation is looking at education and health.
Chief Dr. Moses ADEKOYEJO MAJEKODUNMI Foundation, a not-for-profit organization, started its formal operations in 2012 with the goal of ensuring that the legacy of its founder lives on through impacting and delivering sustainable intervention in the area of education and healthcare in Nigeria, thereby improving lives and living. In addition to supporting and solving some of the community's most pressing challenges in a rapidly changing future, MEMF will continue to deliver on its mission of making people's lives better with a focus on girl-child education and out-of-school girls' empowerment in Nigeria.
Okay, so Papa has been gone now for 10 years, and 10 years have gone very quickly, to be honest. But we're left with very fond memories of him. 10 years later, I mean, we hope we'll continue to memorialize him through the good works, as I said earlier, of the foundation. That's the best way. And also through making an impact in our own way, contribution to Nigerian landscape in terms of medicine. So I think that is what we would be memorializing.
I think the next steps for us really would be to consolidate, find ourselves in a position where we can focus a little bit more on specific items. Education is a big one. I think if we look at all the issues that Nigeria had, and if private sector could join hands with the public sector or the government at various levels in improving the outcomes of education, we all know what that will mean for Nigeria in the future.
But as an environmentalist, as somebody who has deeply involved in the environmental protection movement for many decades, I also see us gravitating in that direction at some stage, because if we cannot care for our life support system, then we certainly won't be able to do much about supporting life within that system.
I came across MAJEKODUNMI Foundation when I was in late 200 level. That's when I came across it, and it was my class group chat that was sent. It was like a message, so I had to reach out to the representative.
And so it started from that time, from that moment when they started catering for my medical education, provided everything I needed as a medical student.
We get quarterly allowances that we use to like keep ourselves on financially till the next one comes.
And aside that, they take care of all our expenses, be it school fees, hostel fees, even they go as far as buying us textbooks and clinical instruments.
And so it was like a dream come true. I'm done with medical school now, and I'm now an officer and hoping to get, to greater heights.
So we've done a lot of stuff for out-of-school girls, helping them find vocational training and giving them a means of supporting themselves.
I've been casting for it for so long because that's my dream, to become a fashion designer. But at times when you wish to do something and you don't have the privilege or the financial something to support yourself.
I saw MAJEKODUNMI Foundation for an display. I'm hearing about MAJEKODUNMI Foundation. I don't know the opportunity. I heard about the program on the radio, so I applied for it. So from there, we go for interview, we are choosing. So from there, they sponsor us.
I just want to sanwó gbogbo ẹ̀kọ́ ṣe wá, but ti sanwó everything. I need anything láti máa bọ́dà pa. Irú gan títí kan owó mọ́tò owó transport fare wa ló máa fún wa ní every month. So I need láti bọ́dà jù pé ká wá kọ́ṣẹ́.
And even on an ad hoc basis, we've helped individuals who fate has brought to our attention in trying to help them get a better quality of life, which ordinarily they may not have been able to achieve.
I resigned from where I was working, and I've been longing to have something doing. So when the opportunity just came, I was so happy. Let me just give it a try, and God made it to be.
And we are involved in several programs, some of them to do with developing healthcare capacity of individuals and even some institutions, and other programs to develop education within the youth, within particularly the girl child.
I want to say happy 10th year memorial anniversary.
We are grateful to Chief Dr. Mrs. ADEKOYEJO MAJEKODUNMI Foundation.
And to the MAM Foundation, please keep doing it. You have saved a lot of lives. I'm one of them. I mean, I don't know where I would have been without you, true God. Thank you so much. A young girl is so grateful.
Celebrated 10th year memorial. His legacy lives on. Chief Dr. Moses ADEKOYEJO MAJEKODUNMI Foundation, Education and Healthcare.
10 years and counting. There's still a lot of work to be done in our nation, but the Moses ADEKOYEJO MAJEKODUNMI Foundation is pledged to continue the good work. The chairman of the planning committee for this occasion, Dr. Bangoye, MBBS, FWACP, FRCP, FNAN. I always like pronouncing all those. Don't you like it? And it's evidence, of course, that as a consultant physician and nephrologist, head of the dialysis unit at St. Nicholas Hospital, a board member of the hospital, who does extensive clinical work as an academic and training of resident doctors, the past president of the Nigerian Association of Nephrology and Transplant Association of Nigeria. He, of course, is a very eminent physician who, even as he walks up here, is reminding me that COVID isn't entirely gone. Please welcome very warmly.
Your Royal Highness, sir, 14th Emir of Canada, the Honorable Minister represented, distinguished members of the board and family, distinguished ladies and gentlemen. I would be attempting to summarize in 10 minutes a lot of work that Chief Dr. MAJEKODUNMI had done over the last 54 years of existence of St. Nicholas Hospital. Can I have my slides, please? We all gathered here, 10 years memory of someone who made so much mark in the lives of so many people. But I will be restricting my own comments to what he's done establishing St. Nicholas Hospital over the last 54 years and what we have been able to do in that time frame. So Chief MAJEKODUNMI, can I have the slides, please? Established St. Nicholas Hospital in March, the year 1968. Ever since then, we have grown to become a much bigger enterprise than we were at the onset. As has been said, he was the first ever Minister for Health. When he left his position as the minister, came and established St. Nicholas Hospital. And at that time, it was the first ever multi-specialist hospital established with all the various subspecialties represented at the very highest of levels. Since then, his son, our current MD and CEO, has taken over the reins of running the hospital, and he has taken it upon himself to expand the frontiers of what St. Nicholas has been. Currently, aside from the main hospital, we now have various branches, and he was responsible for the first of those branches in Victoria Island, exactly about 8 years ago. We moved on to Lekki Free Trade Zone. Shortly after that, we now have another hospital at the Maryland Hospital in Maryland. And most recently, this year, we've established another branch in Surulere. So we now have 4 branches of the hospital. Thank you. So that is the legacy of who we're celebrating. Next slide. And our mama, who we've also made reference to, who was his partner in starting of the hospital, who died earlier this year. The next slide, please. And of course, our current MD CEO, who, like I said, has expanded and modernized the hospital. He's also someone who's taken after his father and is very keen on charity and giving back to the community. We now have a board. Our board chairman currently, unfortunately, is not able to be present with us today. The next slide. He's Mr. Danago. And of course, we also have a board consisting of members of the family and of course a few other distinguished people. Next slide. Next slide. So our mission is as stated there, and this more or less is to represent what Chief Dr. MAJEKODUNMI has been about all through his life. To serve the healthcare needs of our community by providing comprehensive care, which is primary, secondary, tertiary care. In the process of that, to prevent illness, relieve suffering, restore health, and to do this all with advanced procedures and modern technology within the available resources, but doing it in a caring and compassionate way. The next slide. And we expect that by doing that, we'll be the national leader in healthcare delivery in Nigeria. The next slide. So the key points are that we're a top quality healthcare institution. We provide primary, secondary, and tertiary care. We provide it to all social classes. We're not one of those that restrict ourselves to just the privilege. We continuously improve ourselves. We are a referral center to most other centers. Next slide. And our core values, preceding slide, please. And that we're caring, organization that is in leadership position and that uses technology. Next slide. So SNH over the years, what have we done? Like I said earlier, we're pioneers in being private multi-specialist hospital. We're pioneers in having an ICU in a private hospital. The very first ever IVF successfully done in this country, Nigeria, was actually conceived in St. Nicholas Hospital in the early 80s. Not many people are aware of that. Of course, we pioneered kidney transplants in Nigeria and in the West African sub-region. We do that laparoscopically. We're pioneers in therapeutic apheresis. We pioneered regenerative orthopedics. And we're one of the few hospitals that pioneered the implementation of effective electronic medical records. Next slide. But in more recent times, the next slide, please. We've moved on to what I think is now one of our core strengths, which is our focus on training. We're one of the few private hospitals that offers training to medical house officers, and we've done so for over 30 years. We're the first private hospital to be granted accreditation to train intern nurses, and we also train intern radiographers, laboratory scientists, pharmacists, and medical records officers. Or more recently, we've been accredited by both colleges to train specialist family physicians. So we're now a training institution, we're now a teaching hospital, and I'm proud to say that every single candidate that we presented at the exam have passed our first attempt. The next slide. So we see over 50,000 outpatients per year. We have over 2,500 admissions yearly. We carry out over 1,000 surgeries, and we have over 500 deliveries every year. The next slide. But of course, permit me to spend some time on what we do in our dialysis and transplant unit. The next slide. We carry out over 5,000 sessions of dialysis every month. Next slide. Last year, we saw over 169 cases requiring transplantation in that one single year. The next slide. We pioneered plasmapheresis, which is a means of enhancing our transplant potential. Next slide. And as I said, we pioneered kidney transplantation. And these are the numbers that we've done over the years. And last year, we did almost 50 transplants successfully in the hospital. Our radiology unit is also very strong, and we have full capacity to do all forms of radiology. Next slide. And most recently, we have also obtained COSASA accreditation. We are one of the very few hospitals that have that international certification. Next slide. Of course, we have our own problems, and I put this in just to show that it's not all rosy. And this is a problem that I hope the panel will be discussing during the course of our discussions later today. These are the problems with staff attrition. And these are the numbers over the years that are, I think the term for it now is jackpot. And you find that this spans across both non-clinical and clinical staff. But you'll find that it's worse amongst the clinical staff. Quite significant amongst our nurses, and quite significant also amongst the doctors. Next slide. And the reasons, all of them are going abroad. Next slide. We also have international alliances, one in healthcare. We're likely to transit into the teaching hospital of an international-based medical school very soon. And we have all sorts of international alliances that we hope will stem the tide of this jackpot syndrome that we're starting to see. Next slide. Of course, we leverage a lot of technology, and for those of you who are patients and are not aware of it, we do have an SNH app, which I would encourage all of you to download and to use appropriately. Now, into a little more detail, we'll be going into a film which chronicles a little bit more of what we as a hospital have done. And I'll ask the technical team to please put on the film. Thank you very much.
set up by Chief Dr. MAJEKODUNMI when he left his position as the Minister of Health of Nigeria over 54 years ago.
He initially came back to Nigeria in the 40s and went to work in Calabar and found that a lot of the pregnant women were not getting good antenatal care, so the outcomes for the babies were bad. He then went back to Ireland and studied obstetrics and gynecology, and he came back to Nigeria.
And since then, we've tried to maintain that quality and safety standard. As our mission statement says, we are set up to serve the healthcare needs of our community, and we propose to provide comprehensive care, which is primary, secondary, and tertiary care, and in the process to prevent illness, relieve suffering, restore health, and promote well-being. And we propose to do this during every stage of life, from conception to geriatric patients. We provide it using advanced procedures and modern technology, and also within our available resources in a focused, caring, compassionate way that focuses on the safety of our patients in providing that care.
I do not think we should provide any service here. Anybody should have a service here that I will not be able to use myself. So if my wife wants to have a baby, she should have a baby here. If my children want to have care, we should have it here. So the care that we give to everybody and anybody, no matter the person's social status, should give a certain quality, and the quality that is good enough for me. If it's not good enough for me, then I don't think it's good enough for them. So we've done this accreditation. We have a quality department that looks at what we do, but basically is that the quality of care should be, if it's good enough for them, then it should be good enough for me.
And that has been our mission and our vision since we started off several years ago. We have been noted for providing quality care, but more recently, we have now focused on several other things. We have expanded our services, and contrary to what happened 30 years ago, we've now expanded and now have branches in Victoria Island, which is basically a clinic. We have a branch at the Lekki Free Trade Zone, which is an industrial clinic for now. We have another hospital at Maryland, the St. Nicholas Hospital at Maryland, which also provides both outpatient and inpatient care. And the latest addition to the services that we render, of course, is the St. Nicholas Hospital at Surulere, which would also provide primary and secondary care and offers both outpatient and inpatient care for our clients living in the vicinity of Surulere.
Patient safety is key, and we've looked after the St. Nicholas family. St. Nicholas staff are like family. So we've had people who worked here and now their children work here. We've had people who've been with us for over 35 years and still love it.
My name is Osaji Stella. I had operations here at St. Nicholas Hospital and in the lab also. I've been here 24 years running now, and I can tell you it's been an awesome experience and quite a journey too. I remember when we first started out here at the lab, we didn't have all of this equipment in place, and we've transitioned to where we are right now, currently employing the state-of-art equipment that we have, be it chemistry, be it microbiology, or hematology. We are open 24/7, so at any point in time you walk in, you'll be sure to have a scientist on ground to attend to your needs, and our turnaround time are quite enviable. I say enviable because I know that we surpass all of what is happening in our environment. So yes, we should be your first choice and only choice if possible, because we guarantee that you get excellent delivery of services from the laboratory.
My name is Bonani Kolajo. I'm the Chief Nursing Officer at St. Nicholas Hospital. and the position that I held in the last 7 months. I started my nursing career in St. Nicholas Hospital way back in the 80s, and after that, I relocated to UK. Because excellence thrives in St. Nicholas Hospital, I had to come back to give back to my community. My name is Muson. I'm a nurse. I've been here in St. Nicholas Hospital practicing nursing since 2009, that's 13 years ago. Nursing practice in St. Nicholas Hospital is an evolving trend. We work with state-of-the-art equipment. We manage our patients conscientiously and with the latest technological equipment, as I said earlier.
We've also focused a lot on improving the quality of care that we provide. And quite recently, as would have been evident in the news, we were accredited by the COSASA as the Council of Health Services Accreditation. Our hospital was accredited and certified fit to provide services at international standard. And that is one of the main things that one feels particularly proud of, as not many private or public hospitals currently in Nigeria have that accreditation in place. We've also recently focused on training, and we have subsisting accreditation to train intern house officers or medical doctors for their first year of practice after their medical student days. And we've done this now for well over 30 years, and probably one of the very first private hospitals accredited to do so, and one of the only ones that has consistently sustained that accreditation and have trained hundreds of medical officers over the years.
My name is Angela Boteku. I'm a medical student, and I'm currently having summer practice or an internship at the St. Nicholas Hospital. So far, I've been only here for about 2 weeks, and it's been such an amazing experience. I've learned so much. I've met with so many intelligent doctors and amazing healthcare officials, and I find it very interesting that even after 50 years, over 50 years of existence, this hospital still operates. 21st century healthcare is up to standard, and you're assured of the best healthcare in St. Nicholas Hospital.
At the beginning, that is the beginning of St. Nicholas, we were known mainly as a pediatric and O&G, that's a women and children's hospital. If you look at our logo, you can see the emblem or the logo is a woman carrying a child. So it was a mother and child hospital. We've kept that strength of having mother and child, but there are a lot more hospitals and clinics that have opened that serve that. We always try to be relevant. I'm sure everyone knows about St. Nicholas and our kidney transplant program. We have, I can easily say, one of the best dialysis centers there are in Lagos and maybe in Nigeria. And we do a lot of kidney transplants.
More recently also, we were accredited and became the first ever private hospital given accreditation to train intern nurses. The training of nurses has recently shifted to university training, where they're now required, like medical house officers, to do 1 year of internship. And we became the very first private hospital granted that accreditation to carry out that training. And we've done so successfully for 2 cycles now.
We pioneer so many programs in Nigeria. In St. Nicholas Hospital, we are the only private hospital who has been accredited to pioneer the nursing internship. And this we have had positive feedback about since we started. We are looking at enlarging this process of this internship to accommodate the NYSC
so that after their NYNC, we can bring them to St. Nicholas Hospital to continue the excellence nursing care.
Nursing care in St. Nicholas Hospital is commendable because we are strong on infection control, and that I cannot compromise. That's why I still, love to work with St. Nicholas Hospital.
Our intensive care facility has also always been there. One of the very first private hospitals that provides such critical care to our clients. And we have various levels of that care, from the critical care unit to the high dependency unit and to the step down unit, all with successful outcomes.
We will continue to ensure primary and secondary care, that's from vaccinations to open heart surgery, can be got here. We will still ensure that we look after our community. We do some free healthcare projects. We'll continue with that. And we'll continue to look after our staff.
We take small steps in the right direction. So we'll continue to take small steps. And sometimes if we have the opportunity, we'll take a big step. We'll generally take small steps, but in the right direction. I think that's very important. Because you can, if you stand still or you don't do the right thing, you tend to fall back. So you need to take the right decisions and keep doing it.
We're proud of our legacy, of the legacy that we've inherited from the founder of the hospital. We miss him dearly. It's 10 years this year that he passed on. And we hope that wherever he is, he will look down with happiness that we have been able to sustain that legacy that he bequeathed to us.
So in the future, I see us continue to do what we're doing. Maybe opening of some more branches, I don't know. Was one of the things that my father always said was that we shouldn't expand more than where we are now because it's so difficult to manage multiple locations, and it's true. I found that to be very true. We expanded more. We now have 5 locations, and it's a job to keep them all at the same standard as the main one. But we're making good progress. So in the future, I see us staying where we are. So we managed to stay in the relevant group of hospitals in the past 50 years. So in the future, I see us also staying within the relevant group of hospitals in the country.
My name is Dr. Mbangwe. I'm the clinical director here at St. Nicholas Hospital.
My name is Delise Claudenin. I am currently the general manager of St. Nicholas Hospital, or you could say the chief administrative officer.
Dr. Dapo MAJEKODUNMI. I'm the MD, medical director, and CEO of St. Nicholas Hospital.
Your Royal Highness, distinguished ladies and gentlemen, very appropriate applause. But since we're here in the room and a lot of those who keep this wonderful hospital going are not with us, they're doing their job a couple of miles away from here, can I ask those that are members of that family of St. Nicholas Hospital, please stand up so we can applaud them all together properly. Boris Johnson would be very jealous. Thank you, Dr. Dapo MAJEKODUNMI, for, as it were, putting your money where your mouth is. I took particular note of the fact that he wants the standard to be good enough for his family. So it's an excellent opportunity for me to welcome Mrs. Omola MAJEKODUNMI, his wife, and his 2 beautiful daughters, 2 of 4, that are here this morning. You can stand, please, so everyone can see. Welcome to all of you. The MAJEKODUNMI family is enormous. It's huge. It's an important family in Ogun State. And Chief Architect Olufemi MAJEKODUNMI is, of course, an important chief in Egba land, but also the eldest son of Chief MAJEKODUNMI. Unfortunately, he and his lovely wife, Nancy Victoria, are not able to be here this morning. They're very far away, but of course he radiates his love and his humor, and he's probably watching online as well. I think every occasion without him misses a little bit because of his sense of humor. But fortunately, we have his son here today to represent his father and the MAJEKODUNMI family, and he's going to give a short address. Mr. Deji MAJEKODUNMI.
I'm going to start out by reading an address which was sent to me by my father. Your Royal Highness, Honorable Minister, ladies and gentlemen, I thank you all ago at the age of 96. I regret my inability to welcome you all in person due to my presently undergoing medical treatment at this time outside Nigeria. I have therefore requested my eldest son, Deji, to represent me, welcome you all, and deliver this message on my behalf. Today, we celebrate the life and achievement of a great man of whom all his children, grandchildren, and great-grandchildren are very proud, and who has left a great legacy, not only to those of us, his offspring, to inherit, but also the rest of humanity, especially in his chosen field of medicine. We, his children, consider ourselves so blessed by his legacy that even the mere mention of his name continues to open doors for us and our children and grandchildren. All this he could not have achieved without the active support of all of you here today, and many others all over the world that are no longer with us. May the Almighty continue to imbue you all with his abundant blessings and mercies. Amen. Warm regards, Architect Chief Olufemi MAJEKODUNMI. I would like to say a few words of my own as his grandchild, and I'll tell it in a story. About 15 or 16 years ago, I really started bonding with my grandfather. As you know, in Nigerian society and Yoruba culture, the children are to be seen and not really heard. So as a grandchild, I never really had the opportunity to actually just talk to him as two people, as human beings. But I got this opportunity about 15 or 16 years ago. I work in St. Nicholas House. I'm an architect at the top of the building. And he needed help with some things in the hospital downstairs. We wanted to replace a generator. I think we wanted to do a borehole and things like that. So I had this very unique opportunity 15, 16 years ago to interact with my grandfather at a human level. And we had the opportunity to speak about many things, speak about family, speak about the past of Nigeria, speak about the hopes of Nigeria into the future, and just get a general feel for somebody of a very different generation to myself. And it was really insightful. I learned two clear things, everything. You know, as an architect, I'm used to documenting things, interacting with clients and things like that. So I knew that. But my interaction with my grandfather showed me a different level of that. When we're buying this generator from Leventis, you know, I would be his ADC, so to speak, and I would go to Leventis in Papa, I think, and go and view the generator, take records of the engine number, the alternator number, record all those things, and then write a letter, which I would draft. If Gloria is here, I don't know where she is, if she's here, and she would draft this letter, and we would go through it together, and we would submit it to Leventis. And we went on and on doing this. It was a very tedious process, I felt at the time, but we did it that way. We acquired this generator at great cost, because the cost of generator then was 3 times the cost of St. Nicholas House, the entire building, when it was built in the 80s. That's to show you the inflation and the devaluation of the Naira over time. And we got a warranty from Leventis. It was a German generator, MTU. And it was very specific in that warranty that it must, they would provide the diesel fuel for the generator for the warranty to last, to going to be covered. Anyway, the building managers at that time felt that it was unnecessary. Let's just, we'll supply our own diesel and everything. And we captured that in writing. Needless to say, the generator developed faults, and it was seen that it was due to impurities in the diesel. So the fuel injection system, which is probably 25% of the cost of the generator, needed to be completely changed. Unfortunately for us, because of all that documentation, it didn't cost us 1 penny. So I always remembered that if you document, to this day, I have emails from 2004. So anyone sends me an email, I can bring it up almost 20 years ago. So I've always kept that in mind. I just want to say another thing. I know I said it was more professional, but one thing I enjoyed in that time was I was in a very fortunate position. I worked in St. Nicholas House. My father's an architect, so I'm an architect as well. So I had the wisdom of my father, and I had the wisdom of my grandfather at the same time. You can't buy that type of wisdom. And it helped me to realize what fathers are really all about. I know mothers, we talk about mothers in laws, Mother's Day and all those things, but I want to dedicate this to my grandfather, my father, and all fathers out there. From what I've been taught and I've seen, fathers are supposed to be impactful. We may not necessarily be around all the time, but we should be impactful. Your children should know there's a difference when their father is around. When he's in the house, they should know their demeanor should change. And that is how I've always felt around my father. And I thank God for the time I spent with my grandfather back then. So that's all I wanted to add. Sorry, I said 2 things. 2 things. The second one, my grandfather said, never rent your residential property to a lawyer. Or avoid renting it to a lawyer. Thank you very much.
Very well said, Mr. Deji MAJEKODUNMI. All that recording and documenting means, of course, he's going to have to write a book, right? I already have a title for him. Hanging Out with My Dad. How about that? Well, thank you very much. Just another reminder of what an important impact Chief Dr. Moses MAJEKODUNMI made, not only on people around him, but especially his family as well. Your Royal Highness, distinguished ladies and gentlemen, 10th year is also a year to look back at the Nigerian healthcare system, the past, the present, and the future. We've talked all morning about a man who made sure that his past, present, and future were all brought together in creating excellence in all the institutions he was involved with. This morning, it's my great pleasure to welcome as our keynote speaker, Professor Adesegun Abudu, FRCSP. Here, like all the other very senior medical people here, have a lot of letters after their names. But his are mostly concerned with orthopedic oncology, reconstructive surgery. He's been working a lot in the United Kingdom, in the University of Birmingham, where he's a professor and consultant orthopedic surgeon at the Royal Orthopaedic Hospital in Birmingham. It might lead you to know he's one of the few nationally recognized bone cancer specialists in the United Kingdom, with less than 20 such specialists in the whole of the United Kingdom. He passes on his knowledge. He's involved in training senior orthopedic consultants in several countries, including Japan, Canada, USA, China, Greece, India, Malaysia, Italy, Indonesia, etc., and regularly supervises postgraduates. In the last 12 years, he spent a considerable part of his time to improve the quality of orthopedic surgery in Nigeria. That's what I call jackpot reversed, because we talk a lot about people jackpotting, but there's so many more that are coming back and giving back, and they also should be recognized and applauded. Your Excellencies, distinguished ladies and gentlemen, he has an excellent write-up on page 12 of our program, which I hope you will read and absorb. But may I just add that his hobbies are seeing nature, rambling, holidaying, and spending time with his family. There is one other thing he loves, apparently, which is rugby. And I don't know if it's appropriate for an orthopedic surgeon to be so involved in the sport of rugby. But that's where a lot of his patients must come from there. Please join me in welcoming Professor Adesegun Abudu, our keynote speaker, Nigerian healthcare system, past, present, and the future.
Thank you very much, Mr. Kipube. As an orthopedic surgeon, I can see that we've been seated for quite a while. So could we just quickly stand up and stretch our joints and back so that, because I'm here to give a lecture today, not necessarily to care for people. Good. Now that we have done that, we can sit down and be more relaxed, refreshed. Your Royal Highness, the representative of the Federal Minister of Health, members of governors of Dr. Chief MAJEKODUNMI Foundation, distinguished ladies and gentlemen, it is really a great honor to be invited here today to present this lecture. Because I'm going to be showing a few graphs and some x-rays, may I just ask if we could dim the light a little bit so that we can see the illustrations. That's perfect. Thank you very much indeed. That's a delay. Okay, that's good. We've heard a lot about this honorable gentleman. And for me, it's a real privilege that I'm here today to talk about this highly respected and very accomplished statesman. We've heard, and I know because I've read his biography, which I will really recommend to everybody because you will learn a lot, and you will learn a lot, not only about him, about what statesmanship means, and about how our Nigerians of the past behaved and what they thought about the country. So please, I recommend that autobiography to you. He was an eminent doctor, an obstetrician and gynecologist, par excellence. But not only that, he took a lot of interest in pediatrics as well, because he realized that mother and child goes all hand in hand. He was a visionary leader and a great administrator, as we've heard. But above all, and as we can see here today, he was a very traditional man and a family man to the core. And you can see that from the children and what the children and the grandchildren have said about him. So really, this is the most complete gentleman. Now, I have a personal reason as well, and to be here today. Like the Royal Highness said, I was very privileged and I was very grateful when I was called and invited to give this lecture, because this is someone that I have heard a lot about from my own family. He had a lot of personal connections to my family. He was from the Okeone in Abeokuta, and that's where my own family originates from as well. Like his father, he was the Otu of Egbaland, and the Otu of Egbaland was the highest traditional title that could be bestowed to any Okeono man. And it was quite unusual for the title to pass directly from father to son, but it did in his own instance. And above all, on a personal, just like the Royal Highness has said, he also delivered my own very cousin, my very first cousin. And in my family, we always hear stories about the special care that is provided for my auntie, Mrs. Raulat Abudu of blessed memory, during a most traumatic and difficult delivery. And that delivery resulted in a successful delivery of a boy called Debola, who is now a very successful businessman. He gave a lot to this country and to the public service. He was a former administrator of Western Region. He was in the Senate of Nigeria. He was also the former Minister of Health, who contributed and shaped the health service of a newly independent nation. We've heard that he was instrumental to the founding of the Lagos Medical School and the Lagos University Teaching Hospital. But above all, one thing that really is the fact that he had a very close connection with my own father, Alhaji Yusufu Moyosore Abudu. The two of them were instrumental to founding the community school called Okeono Grammar School in Abeokuta, which I believe was the first community school in Nigeria. But certainly, I tried to confirm that, but that's what we've been told. But certainly, the first in Abeokuta and in Ogun State of today. That school is my alma mater. So I'm a direct beneficiary of his legacy, and for this, I'll forever be grateful. He took part in several community services, as we have heard. Here is my uncle, my uncle, who, because of infant mortality, people dying a lot in the community. And when he became a little bit more aware and had the resources, built a community hospital that he fully equipped for the provision of free medical services to the community on a non-profit making basis. And who was the chairman of that commission of the hospital was this same man, Chief Dr. Moses Adekoyejo Majekodunmi. My uncle remembers the day, and he was very pleased and proud that I will be giving this lecture today. So, from what I've said, you can now see why I feel really privileged to be about the topic of today. Sorry, it's a very sensitive, which is Nigerian healthcare, to look at the past, present, and hopefully look at where we might go in the future. What I'm going to do, I'll just say, if you can just advance the slide for me, please. This is not working. Next slide. Next slide. What I'm going to do today is to review the parameters of health outcomes from about 1960 to the present day, and look at where we are projected to be in the future. And I think we should compare those outcomes with other countries, which I will go to, and explore ways for improvement in a way that hopefully Dr. Chief MAJEKODUNMI will approve. Next slide. Now, for the comparison, what I'm going to do is give where Nigeria, go back please. Yeah, give where Nigeria is today and compare that with the average for the sub-Saharan region. And also compare those figures with the figures from countries like Afghanistan, Libya, and Sudan, who have similar socio-economic, if not worse, than Nigeria today. Look at some selected African countries like Togo, Ghana, Rwanda. This will be the team. But besides looking at those people who are contemporaries in socioeconomic problems, look at a country like Cuba, who is not so rich, and compare that with what can be achieved if we had effective leadership, effective direction for healthcare. And above all, as well, compare it with rich countries, which we consider to be the ultimate of where we might want to be well in the future. Next slide. So let's first look at life expectancy. A person born in Nigeria today is expected to live till only 55 years. Okay, that's the average life expectancy today. Although that is almost double what it was in the 1960s. So in 1960, our life expectancy was about 32 years. It has improved, but it is still far behind the average for sub-Saharan African region. I'll just wait for the excellency. I was thinking about that. Yeah, it is far worse than other countries like Afghanistan, for example, Libya, Sudan, even has more. After 30 years of war, they still have better life expectancy today than we have. And look at that for other countries like Rwanda, for example. In Cuba, the life expectancy is as high as you get in UK and in USA. So that means that the life expectancy is not just a function of wealth. Okay? What Cuba has done is to prioritize healthcare. Okay? And that is what we say. But besides that, is that when you look at it, is that we are projected that in 80 years' time, we would only reach 70 years. So in 80 years' time, somebody born in Nigeria will still live lower years than somebody born in UK today. Now, believe you me, this is a situation that we cannot allow to continue, and we need to look at ways to change. Next slide. Besides that, let's look at infant mortality, which we define as the number of children who die before 28th day of life. In Nigeria, in the 60s, about 70 out of 1,000 children born would die within the first month of life, roughly. It has improved. Now it's 36 that will die. But that number dying is still far higher than the average for the sub-Saharan Africa. It is higher than you would get in Sudan. It is higher, and look at Cuba, 18 times better than Nigeria. And a child born in Nigeria today has 12 times higher risk of dying in the first month of life compared to somebody born in the UK. Next slide. Let's go and look at infant mortality. So if that child survives, if you look at the number of children that will die in the first year of life, we have got better. No doubt about it. In 1950, which was, 300 out of 1,000 children would die before their first year of life. So 1 in 3 children died. And that was why people had many children, because they didn't know who was going to survive or not. We have got better now. 72 children will die out of 1,000 in the first year of life. But that number is still far higher than the sub-Saharan Africa, and far higher than all those countries considered. Look at Cuba, look at USA, look at UK, look 4, whereas we are 72. So that means that 20 times the number of children in Nigeria born will die in the first year of life compared to a country like Cuba. That is not something that we should be proud of. Next slide. You look at every parameter, a child, what is the chance of the child living beyond 5 years of life? Again, we got better because in the 60s, more than 1 in 3 children died before their first year of life. Now, it's less than a third of that. 114 children would die before their 5 years. But comparatively, it is still higher than than most of the other countries that we compare. And these countries, I chose them for the reasons I've said before. Because if you look at Sudan, with all the problems, socioeconomic and political problems that Sudan has had, you could see that the healthcare is still better than it is here in Nigeria today. I've been lectured there, I've operated there, I've seen the facilities. And for me, I feel quite disgraced for that purpose. Next slide. Now, what is the most common cause of death? About 70% of these are due to communicable diseases. Most of them are neonatal disorders that children are born with, malaria, diarrhea diseases. What we were told, my classmate is there, Professor Somebody, I think you will still remember what we were told, fever diseases. Okay, and that's what kills us. Okay, more recently, we are beginning to see non-communicable diseases like ischemic disease, stroke, and meningitis. Next. So, if we group that all together, you see that communicable diseases account for 65% of deaths in Nigeria. Non-communicable diseases, 27%, and accidents and injuries for 8%. But what we are witnessing in the last 20 years is that there's a gradual shift from communicable diseases to non-communicable, as well as gradual increase in accidents and injuries with the security and bad roads and all the other situations that we face in the country. Next slide. Of course, one of the determinants, not the only determinant, but one of the determinants of measurement of healthcare is the amount of money that people spend on providing the services. And here, we're not doing very well as well. as a percentage of our GDP, we only spend 3% of our wealth on health. Now, compare that with all the other countries. Cuba, relatively similar to us in economic terms about 20 years ago, maybe even less, 11%. Look at Libya, look at Sudan, 5%. We tried in the early 200s to match that, and we increased our health spending to 5%. But since then, it has gradually fallen. So that is why I really buy into the comment that His Royal Highness made earlier on, that when it comes to the election, these are the questions that we should ask people who come to us. We really shouldn't leave this to end here in this room. We should take it outside so that people know, and we should be asking, what are you going to do about this? Next slide. At the same time, what you can see is that gradually, there has been gradual shift whereby the government is spending less and out-of-pocket spending is getting more. In 20 years ago, for example, when we still have some semblance of reasonable public health, we spent less. Now, we are spending about 70% of that healthcare expenditure is from out of pocket. Now, this has its own problem, health inequalities. What do you do with those people who do not have? Okay, next. One measure of healthcare is the number of staff that you have to deliver the healthcare service. And here, although there's no recognized data as such about what the ideal should be, but we always will tell or could say that the more the better. Because in Nigeria today, from the registered doctors, you could see that there's only 4 doctors per 10,000 people population. And that compares with all the other countries. And you could see that even in somewhere like Libya, they have a higher number. So with all our, with our education, what are we doing with increasing that number? And what even makes it worse is the imbalance in the spread of these doctors. That when you go to the rural areas, you'll find out that the numbers is far worse than what you get there. Next slide. The same goes with nurses. Although we have a bit more nurses, but the fact is still that we are still understaffed in this area. Next slide. And when you look at the number of registered doctors, this is figures taken from the regulatory body. So if you look at the General Medical Council figure in UK has over 300,000 doctors for a population of 67 million. Next slide. Look at Nigeria, 3 times the population of UK and a quarter of the number of doctors. That doesn't seem to make any sense. So this is an area that I think we really have to try and improve in terms of medical education. Next slide. And it's not just in doctors only. That number is ridiculously low for every health practitioner. So you can see nurses lower, pharmacists lower, physiotherapists lower, radiographers lower. And these are the people, because even when you have the doctors, they still need all these people to support the healthcare. So we need to try and address that. Next slide. Now, if you look at the number of medical schools, for example, UK has 37 medical schools, and of those 37 medical schools, they have 9,500 students, okay, medical students. The universities are now pushing the government to increase that number to 14,500. And yet, look at Nigeria, we have 45 medical schools. Most of those medical schools produce very few number of students. And with the population 3 times that of UK, we have less than half of the medical students. So that means that in the future, we are even storing up problems for this in the future. Next slide. So what do we observe? from all this data is that although overall we have witnessed some improvement in general outcomes over the years, but unfortunately, this still lag behind our comparative countries. Poor health financing remains a major issue in this country, and our patients continue to pay a high price from their own pocket for their health care. The shortage of healthcare professionals, and not only are they short, we have not distributed those health professionals equally between various parts of the country. And this, therefore, lead to health inequalities. And I'm sure if you want study that I haven't seen is to look at that in terms of socioeconomic grouping to see what this thing. Sorry, go back. And we have heard that brain drain is a problem. Yes, it is a problem. But what are we doing about it? Okay. And I think over the years, we have had various strategic health plans, but the implementation of them, on paper, those health plans look great, but their implementation have been extremely woeful. Next slide. So I therefore think that there is need for urgent provision of safe water, because what we need to do is to tackle communicable diseases. If we tackle that, we will see a significant increase and change. It's not that expensive. Nowadays, I don't see anybody talk about water corporations anymore. They seem to have disappeared. Everybody thinks you are building your house, the first thing you think that who is going to dig the borehole? When I was growing up, you didn't think about borehole, and we've all accepted it as if it's normal. These are the questions we should be asking our future elected politicians. We need to improve environmental sanitation and pollution, which is becoming rampant. When I was growing up, we used to have wole that came around health inspectors. They seem to have disappeared. And yet, nobody says anything. We just accept it as if it was known. We need to find ways of tackling poverty, unemployment, and malnutrition. We've heard a lot about that. Because the key to most of these communicable diseases lie in these three. And if we can tackle unemployment, we can tackle poverty, we can tackle malnutrition, we will find out that our health indices will improve. And I heard the very passionate appeal from the chairman of the foundation about environmental and air pollution. This is a big problem, a real big problem. We heard a lot about nature in Nigeria before. Our nature is disappearing, becoming jungle computerization of all things that contribute to healthcare. And these are areas that I think we need to tackle. Next slide. We need to encourage more primary healthcare centers to be built. I believe that just as Chief Dr. MAJEKODUNMI wanted and did for Lagos, and really, you should try and read his blueprint strategy that he presented in 1963. It's a very good read. I believe that each local government really should have healthcare centers, primary healthcare centers. And even at that time, he was proposing that each of these primary health centers should have 4 doctors that will open 24 hours a day. That was 1963, 1961 or so, or thereabout. Okay? And yet, today, we even struggle to find some centers with 4 doctors in the so-called general hospitals in some parts of the country. We need to have more defined roles for secondary healthcare centers, because one of the things I see is that even between tertiary and the secondary, there's so much overlap. And therefore, when you have that overlap, you dilute efficiency. What has a big teaching hospital got to do with treating diarrheal diseases or malaria when they could easily be treated at a cheaper rate outside in a primary health care center? So we really need to have defined roles. of doing this. And I really think that our tertiary centers need to be structured, better funded, and their roles should be defined. And their roles should not be providing primary health services, but rather providing what they are called tertiary health services. I don't do incision and drainage of abscesses. I do something more complex because it's more expensive to get somebody like me to do that. Okay, and that is why we got to try and do next step. I think this gives a unique opportunity for private healthcare services, okay, to really develop and help, because the government alone cannot do it. And I'm really pleased. I'm very, very happy to hear the presentation from St. Nicholas Hospital that you are taking this on. I think that the government needs to support them with special funding, support, tax breaks, for example, to be given. We should have advisory and guidance units. Even if I come today and I say I want to start a hospital in Nigeria today, the problem I would have is so enormous that I would think I might as well just go to Ghana, I might as well just go to somewhere else and set up a hospital. Okay, so we need to look at that. I really think that we need to encourage more primary healthcare centers of single practice GP hospitals, where you come out of the medical school, the week after your NYC, you rent a 3-bedroom house and you convert the kitchen to a theater. Those days should be gone. We really should provide collaborative. People should come in as consultants. And I think if nursing homes, health centers should be built more, and some of this could be private. And I'm sure there's a business case to make a huge income from that. And I think we should encourage large tertiary private centers. So I'm really pleased that St. Nicholas Hospital is going along that way. It was developed in that way anyway, and it has continued to develop. I want to see more hospitals like that, taking training, taking education, taking the best. Why can't we have a Mayo Clinic in Nigeria? Why not? We should aspire. Next. And also, we need to increase our health spending. Minimum should be 5%, in my view, and we should not, and really, we should be going close to 7% of our GDP. Okay, we need to look at how the health, the little bit that we got, how is it even allocated? Now, as far back as the 60s, Dr. MAJEKODUNMI proposed that insurance coverage, that part of the health allocation should be used to fund this. And I sincerely think that is a good way of, this is what I've always thought. So it was good to read that, in the sense that the money disappears and we don't see it. Whereas, if you use part of that health allocation to buy insurance, it would increase the coverage, it would reduce out of pocket, and above all, it would minimize corruption and wastage in healthcare. And even the teaching hospitals can compete along those lines. Get people to come and use the out-of-pocket, and use the insurance coverage within the teaching hospital and get your funding. Sorry, Dr. Miller. Next slide. Okay, I think if you do this, this will lead to improved access of excellent healthcare to a large proportion of the population. It will lead to significant expansion of the current available services, and it will allow us to develop more services both in the private and in the health center. I really think that we need to develop a national center for studies of health outcomes. At present time, getting all our data is very, very mumbo-jumbo. If we have this center, we'll dedicate to that, and when we know our outcomes on year-to-year basis, we can start to think about how we develop and improve. I also think that one thing that has gone lower these days is community health promotion and health education campaigns. This is where NGOs like this, foundation, public, religious, and private institutions have a role to play. Next slide. And also, we need to enhance human capital development. Dr. MAJEKODUNMI recognized that we needed to improve education. So he spent a lot of his time on training. We need to devise strategies to increase the number of training places for all health professionals, including specialists. it pains me when I see people who qualified, who want to be orthopedic surgeons, and they say that they cannot get orthopedic training places here in Nigeria because the teaching hospitals won't have them. And yet, we don't want them to go abroad to go and train. That doesn't add up. They will leave. And in a country where we have less than 400 orthopedic surgeons, to a population of over 200 million, and yet we can't train people. So we need to develop that. Also, I think we need to have a strategy to minimize brain drain. Brain drain, what will minimize that is better infrastructure. Because if you don't have better infrastructure, you don't have better training and development facilities, you don't have wages and above all, professional satisfaction. You're not going to want to stay. But I also see brain drain as an opportunity for us. Because we shouldn't just say it's a bad thing. No, it can be good. What we've got to do is to have a strategy to convert the drained brain to brain gain. I think we have to have that strategy. We shouldn't just sit down and say they're all going. What strategy are we going to have to encourage them back to be better doctors and better nurses and better health practitioners? So we need to encourage diaspora contribution to healthcare, infrastructure development, clinical support, and advice. And above all, I think we need to encourage diaspora contribution to health education. These days of it's me and them. As a diaspora, when I come back and I want to go to university to lecture, I find it more difficult. Yes, everybody in the world is begging me to come and lecture. And yet here in Nigeria, I find it very difficult because they say, he's now come back now, he wants to lord it over us. No, we should have a mindset change. Next slide. So, I would like to just share my own personal story of saying that why we should look at brain drain. Okay, I finished from the University of Ibadan in 1987. I did my housemanship. I didn't have to know anybody. Just as one of the top students, I was given the post. I just got a letter. At UCH, I did my NYC at the police hospital here at Folamo. And then 2 days after getting my NYC certificate, I Japan. Abroad. Okay, you know. And I've been in Birmingham. I was in London initially, and I was in Birmingham. And I've been in Birmingham then, and I've trained all over the world. Over those times, I've been visiting professors in 8 countries. I've been invited lecturers in more than 20 countries. Next slide. Okay. I work at a highly specialized National Center for Orthopedic Surgery with people, these are the staff that I work with. Next slide. And because of the nature of the job, I get a lot of people from all over the world come to visit, and they enrich me, both culturally, professionally, personally, and in terms of professional satisfaction. Next slide. I travel around the world to various orthopedic associations and guest speakers, keynote speakers. Okay. And in my professional role, I run the International Center for Complex and Extreme Orthopedic Surgery. Okay. Most of the patients I treat come from UK and abroad, a lot more. I'm very keen on training, mentoring, and research. But above all, one area that I've spent the last 20 years of my life on is innovation in improving orthopedic surgery. Next slide. And such innovation is saying that there shouldn't be any disease of the bone that we shouldn't be able to treat today. And there is no bone in the body that we cannot replace. So here we have, these are some of the surgeries that I do. Replace the whole of the thigh bone, the whole of the thigh and leg bone. Somebody has a problem there. You can replace that. This involves complex decision making, designing, working with engineers. I work closely with engineers, implant companies to do this. These are all custom-made implants. Knowing what your problem is, designing a personal specific implant to fix that problem. Next slide. And here we have, you can replace, get biologic man. That's a patient with the hip replaced from there to about there. Okay, walking, driving, living normal. Next. And not only that, in the upper limb, you can do the same. The whole of the bone. We've done that here in Nigeria. the whole of the arm bone. We have replaced that here in Nigeria. It is possible. Next slide. And that's on the elbow. And this is here again here in Nigeria, where I could replace the wrist of a patient where the arm has been badly mangled, and we could do that. Next slide. Okay. What of in children? Joint replacements in children carries difficulties because they continue to grow. Metals don't grow. One of the things we did in the early stages is do a lot of research to find out how children grow and what happens if you put metal in the growth plate. So if you look at that, where that line is on top there, that's where the growth plate is, and the bone continues to grow. So we now know that if I put a metal in the right way, in the right direction, in the right position, I can still get 80% of the growth of that bone. And I can then build that shortening into my implant design. Next slide. And this is where we have. This is the sort of design that we have with the engineers that we worked with. And we said, okay, this is what we're going to do. And where the growth, I hope this works. No, I can't see. So, yeah, and where the growth is going to come from is in the part in the middle, where there is, sorry, I'm trying to see if I can get the point. So super. Where there is that little mark at the top there. So the bone can grow. Next slide. Now, in that original design, the way we made the growth is by a key, where we put a key in and we turn the metal and the bone grow, and the metal will grow to maintain the length. But that still means that child has to come in for an operation. So we started to look at ways that how can we make the bone, that metal to grow without an operation. So we use magnets. So we place magnet inside the metal, and when that's the magnet that goes inside that, and when we apply that core on the outside of the metal, we can control it in a way that we can make the limb to grow. And that way, that child doesn't have an operation. It can be done as an outpatient, and that is one of the patients having it done. Nowadays, I even train my physiotherapist to run this bone lengthening procedure. Next. And even in an adult, here is somebody that has had severe injury where that bone is missing from about there to the top of there. We have removed that whole bone. I've put in a spacer, which is like bone cement antibiotics to control the infection. The infection is controlled. By the time it came to me, she was about 10 centimeters short. We could put in a metal replacement there, and to control the soft tissue. Once the soft tissue heals, as she is there now, we can now apply the magnet, and we can now correct that leg length discrepancy. And you can see the bone, the metal expand, and we can control that. And that way, she's just sitting down there with the physiotherapist. My physiotherapist there, just doing that. And when you do that, you can listen with the stethoscope. That is the only time, as an orthopedic surgeon, that I use a stethoscope, to listen and see how that metal is working. Next slide. Next slide. Okay? So, but not just metal. We now try to see, besides using metal, can we use bone from other parts to replace bone from other? Next slide. And that's what we do. Somebody has that there. We can take a bone from the leg, we can shove it in there, we can treat that, and we use that bone. So bone transplantation, we can do that. And even on the same side, where somebody has had an accident, we've taken that bone out, there's a small bone on the side which has a blood supply. If you can move that bone with its blood supply, you can transfer it. And if you stretch it rightly, it will continue to heal, and it will grow. Next slide. And it will develop like that. Okay? And that's what you do. Next slide. Even in the spine, there's some cancer of the bone, for example. That's the whole of the cancer there. It is that this patient will be paralyzed if he didn't do anything. So what do? We can now take that bone out, and we can do fancy reconstructions. We can put in special bones from other parts of the body, like in the leg. The good Lord was very good when he designed us. He gave orthopedic surgeons spare bones. Okay, so we got spare parts. So we can take those spare parts and we can use it like that. We can shove it in, and then that bone will continue next slide. And that will continue to grow. And when we do the CT scans, you can see the back, you can see the bone. And this patient is now a lorry driver 15 years down the line. Okay, next slide. We talked about metal replacement and the problem of growth of metal in children. But why can't we be clever? What if we are able to take the bone from that child with a growth plate from another part and put it on so that that bone just continues to grow as normal with the child? Okay, and this is what we did, where we did some anatomical dissection to find out what supplies the blood supply to the growth plate. Next slide. And from that, this is a 5-year-old boy with cancer, for example, there. We can remove that bone, and I can take that bone with the blood flow to the head of the fibula. We can shove it in, and this is the child, you know, and that bone, next slide. And that bone continues to grow. We reported how much growth can you get from that, and based on that, we can now decide how much bone we need to transfer, what we expect. We can tell the parents what to expect for the future. Okay? But can we not be clever? If a bone is diseased, can we take that bone out, cure it of the disease outside the body, sterilize it, and put it back in the body, and get it to continue to develop? And there is a patient who is only 21 years old, had a cancer in the leg there, and I planned the surgery that, yeah, we can take the bone from there, we can take it from just under the knee to keep his knee joint, and we can, next slide, I'm sorry if you see this blood here, and we can take the bone out there, that's the dissection, that's me doing the surgery, we can remove the cancer from that, and the bone that is left, we can wrap it up, we can take it to the radiotherapy suite. I can apply huge amount of radiotherapy. Next slide, quickly. Huge amount of radiotherapy, which you cannot give to the body. And that sterilizes that bone. So that bone is now back to normal. And you can then put the bone back in. Okay? And that bone heals, and the child continues to work. I've even discharged him now. He doesn't come to see me anymore because he's back to normal. All this, when I talk, people say, you can't do this in Nigeria. No, you just have to have the right facilities. Kidney transplant has been happening in St. Nicholas for years. Okay? If you develop the right expertise, the right team, the right facilities, everything is possible. In the 60s, we were leading healthcare nation. So what happened in the last 50 years? Okay? And here in Nigeria, you see this common condition where people have had fractures before, poorly fixed. We can design that, and this is here where I've gone with the engineers, we've designed something we're going to put in there. Next slide. We put that in, and that is that. And next slide, and that is that once everything heals. Next slide, and this woman is continuing to work normally. Here in Nigeria. Next slide. Okay, and there. Next slide. I've been part of training, teaching, sharing experiences with colleagues, looking at complex problems. What do you do? Don't do this because it won't work. And that is what you gain, because that experience I could bring back. So maybe Japan, as they say. Next slide. But it's not only that. I've been involved in teaching medical students, nurses, really sharing them. But it's not just teaching, but it's even teaching them about attitudes, behavior, communication. Because those are things that I find are now lacking in our healthcare. Next slide. And this is at a church, for example, where I'm just giving community lectures about how to look after your joints, how to do things. Next slide. And why is that important? Because living longer is not the only thing. It's making sure that you live longer well, in good health. So I'm very interested in making sure that people keep active. Next slide. Okay, so joint pains, that's an area that I'm so much interested in. We know that some of us probably suffer that as we get older, usually minor, transient. It's rare in children. If you get it in young people with joint pain, you should be worried. But as you get older, you tend to get that back leg, back neck, we all have it from time to time. Next slide. Okay, so we need to make sure that you are accurately assessed. Next slide. And because we don't want to leave it till next slide. Okay, and two types. Most of this will be due to osteoarthritis, and there are two types of arthritis. Primary arthritis, where there is no cause, and secondary arthritis, where there is a cause, either from an accident or some other things. And the primary arthritis, people say, why me? If you get older, and as we are living older, we are going to see more and more of these problems. In the 60s, when people died at 30, they didn't have the problem. But now, we are getting that. And that's why, as an orthopedic surgeon, I continue to be very busy in the UK. Okay, next slide. And this is in the hip, where the hip is badly damaged. Next slide. And next slide. And in the knees as well, you can see that where the knees is damaged. And it's more common in black people than perhaps in the Caucasians. And if you leave it, it just leads to progressive. And that's why you see people walking like that, and they say they can't walk. Okay? And next slide. And next slide. So this is where, you get somebody has had an accident, is that a fixation like that, which is a good fixation, that joint will heal. But if that fracture, next slide. If that fracture was poorly treated, that's what you see, degeneration of the joint, and then you need that. Next slide. And in the hip, most of the time it's due to avascular necrosis. In this country, is sickle cell disease. That's one of the biggest things. And one contribution that I think personally is that over the last 12 years that I've been coming to Nigeria, we have changed the care of sickle cell disease for hip condition in this country. I'm very happy to see that, because in the past, it just used to be poorly treated. And I remember my first clinic here in Nigeria, a lawyer, sickle cell patient, came to me and said, I need a hip replacement. And, and nobody here in Nigeria is telling me that, because she has Googled it. And he said, because what everybody else was saying to her didn't make sense. And I completely agreed. And that really made me dedicate myself that we must do more, not just to teach the professionals, but we have to go to the patients as well, so that they're able to demand their rights. Next slide. Yeah. Okay, so, you lose weight, you do all that. Next slide. And, it usually leads to pain and deformity. Next slide. We can treat it, usually by losing weight, some painkillers, but sometimes when that doesn't work, we can do injections, we can do keyhole surgery, and sometimes we can do joint replacements. Next slide. Okay, so injections is temporary, usually, but it's established for so many other things. Next slide. And the keyhole surgery, we usually do it for torn cartilage, particularly around the knees, where we can do that. And, and next slide. And you can see that. You can see the torn cartilage there, and we can remove that. And the patient just goes on the same day or overnight in bed. Okay. So the hip replacement means that we remove the diseased bone, and then next slide. We put in a metal to replace that, and then when we finish, next slide. It's like that. Okay, and next slide. And the knee, where the knee is so badly deformed, means that we have to correct the deformity first before we actually replace it. And when we replace it, the knee will be straight. Next slide. And then you get the same knee like that. And that's what we should be doing. Next slide. Okay. And these are the best operations, because the economists have something we call quality of life measures. And when you look at that, in terms of the quality, is for every pound that we spend, is the one that gives us the most functional recovery for that. Okay? And it lasts usually 10, 15 years. Next slide. Okay. But it's not just doing it. Like I said, for tertiary services as part of our healthcare, we need to make sure that we have the right skills. We have the right design, we have the right infrastructure, we have good nursing care, and we have the good rehab. Next slide. Next slide. Okay. And when we do that, this is one of the things that drives you as a professional. When you receive this sort of letter from a patient, thank you, doctor, for making me have my normal life back. And that is what Dr. MAJEKODUNMI did all his life, trying to make people to have normal life back. Now, we shouldn't just beat ourselves. If we have these facilities, it is possible to get that sort of advanced care at the same level or even better outcome here in Nigeria. And these are all my own personal results because I keep my own results. I've done over 300 cases of this now, going to 400. And when you look at the outcomes compared to the UK Joint Registry, National Outcome, you could see that our outcome here is favorable compared to that UK National Outcome. So we should do this. And this is why I said that it's very important for us to have outcome studies so that we know how bad we are doing, how good we are doing, and which areas we need to improve. Next slide. And you can still remove the bone like that. These are big surgeries here in Nigeria. Somebody with tumor there, that we can take that one out and we can, next slide. And you can replace that here. And next slide. Similar thing, somebody has had severe fractures like that and the bone is completely damaged. This patient in the past will be confined to bed, but he may not die for the next 2 years, but is bed bound. So what do? Next slide. We can replace that, and that patient can get up and carry on with life. Next slide. The same with the arm, and then you can replace that. Next slide. And then you get the arm back working normally. Next slide. And next slide. So for you to do this, you need a team. We shouldn't be individualistic. We need to harness every part that we can do to do this. And I think when I read through the autobiography of Chief Dr. MAJEKODUNMI, one thing that he stressed and he talked about was all his team members at the Massey Street Hospital. He remembered their names, he remembered what they did, he remembered what they did with each operation, and it was really, really very nice for me to hear about. Thank you. So the strategic goal, really, for our future healthcare should be that we have a strategy to provide good quality healthcare for all Nigerians. That care provided here in Nigeria, by Nigerians here in Nigeria. For me, I think this is a matter of national pride and priority. And these are the goals that Dr. We need to do this because this is his legacy. And thank you all for listening.
Your Royal Highness, distinguished ladies and gentlemen, Professor Adesegun Abudu, as you can see, is a consummate lecturer, has contracted an hour into a much shorter space of time for our benefit. In fact, it should be, I think, probably in the afternoon session where he can continue to pass on more knowledge. But for us, we had to listen to him to get the salient points. And when you link the past, the present, and the future, I think his lecture talked about how Professor MAJEKODUNMI planned for the future. He made his mark, created things, but he kept planning, and that planning is being carried on by his son and the other members of the team today. The present, well, it's quite clear that we've fallen behind, and some of those reasons are not far-fetched. When you look at when you compare the statistics of other countries, which we must do, for our population, we really have had our population grow faster than we'll be able to grow the facilities and the resources to manage the health. So what about the future? I think Prof showed with the last part of his lecture how important it is to harness the knowledge of those who have acquired it, whether it's here or abroad. If they're abroad and they can make an impact in other countries, you should encourage them to come back here and continue to give back some of that knowledge which they perhaps could not acquire while they're in Nigeria. So there is an important role for them to play, and we shouldn't just think about people going away. We should think about the contribution that those who go away can make if they came back or helped in some other way to develop healthcare facilities. I think I've tried to maybe draw some conclusion from his lecture, but I think it's more important that you acknowledge him once again by a big round of applause. Our panel discussion is going to be brief because, as you know, I'm a stickler for time and I've been told to keep everything well under control, and we've got a mere 20 minutes. So it's my great pleasure to very quickly invite Dr. Tunde Ajayi, who's representing Professor Akiabaram, Commissioner of Health for Lagos State. He's the Special Assistant to the Commissioner on Health. Lagos State, of course, probably leads the nation in healthcare at the moment, so they always have a large role to play. Dr. Tomi Koka, Commissioner of Health for Ogun State. Ogun State, of course, is a partner, I would say, to Lagos State in the way they have been trying to ensure that healthcare for the people of the state are well managed. And Professor Chris Bode, Chief Medical Director of LUTH, representing in the earlier part of this occasion the Honorable Minister for Health, but now representing himself, which you should find very easy to do. I don't know if Dr. Femi MAJEKODUNMI was able to stay long enough to be a part of this. I don't think so. Regret his absence. He was called back to Ogun State by his principal and had to leave us. So our panel discussion shouldn't take too long. The microphones are with you and they're on. But maybe I can start with Dr. Tunde Ajayi, Lagos State. Maybe just 3-4 minutes telling us about what the experience of Lagos State has been in the area and trying to relate it also to the past, the present, and future of healthcare.
Good afternoon, everyone. Your Royal Highness, ladies and gentlemen. I'm standing in for the Commissioner for Health. He's unavoidably absent. He's currently with Mr. Governor at the inspection of a 500-bed psychiatric hospital that we're putting together in Ekpe, Lagos. We're probably walking during this event. So I'll be talking quickly about Lagos, the past, the present, and the future. The past, I can say, up until when I got very involved, and that would be from the time I was a student in Lagos, in the College of Medicine. I think that in the past 3 years that we have been in government, it's been really different. So if we look at the key things from governance to human resources for health, to other healthcare strategies, to how we managed COVID, and to how we have invested in healthcare, I think we have done tremendously well. In the area of maternal mortality and infant mortality, a lot of work has gone into it. Dr. Mololu, who is right seated in the front here, is the MD of Lagos Island Maternity Hospital. All of his life's work really is improving maternal health and making sure that no woman dies while trying to have a child. On top of all of that, Lagos has tremendously and consistently funded research in all of these areas. So I would say, for instance, we have funded research on the travel time of women, travel experiences of women from their houses to hospitals. I would say that in terms of infrastructure for health, we're currently building a 280-bed hospital at Ojo. It's right at the junction, at the roundabout there. All of our general hospitals are well funded, equipped. We have people running them, doctors, health professionals. Also, in terms of the attrition that was earlier alluded to, of course, every hospital right now in Nigeria has experienced that mass emigration of health professionals. Last week, for instance, was saying some days ago that about 4 nurses resign every day, saying they are going to the UK. All of my classmates, for instance, from the College of Medicine, Lagos, more than 70% have left. But some of us are very invested. And the goal really is to make sure that those that have decided to stay back home, get to put in the work. At the end of the day, nobody's going to do the work for us. Nobody's going to come back to improve our health systems. Nobody's going to come back to develop a country for you. It's just going to be you and you alone. So over time, over the past few years, I think we have done really great work. Looking at the future, or looking into the future, first, we're developing a lot of work around biosecurity, biobanking, and the new frontiers of medicine, cutting edge research, cutting edge infrastructure, investments, and all of those things. So if we get into specifics, over the course of this conversation, then I'll be able to shed more light, and then we'll take it from there. Thank you very much.
Thank you very much for your opening there. Perhaps you could have a thought, because I'll come back to you specifically, because being in government and relating to our lecture by Prof, this question of brain drain, does the state have any strategy around the brain drain? I mean, you should have an approach you're taking to minimize all this or to take advantage of it, especially as it concerns a lot of clinical staff, nurses and doctors. But I'll come back to you, but maybe at this point, the person who should be worrying a lot about the brain drain and people he's training at what is a great expense in Nigeria are being trained very cheaply for those abroad, it would appear, because that's why there is such high demand. So, sir, Luz, your experience, past, present, maybe the future, more important for you, Professor Chris Body. 3-4 minutes, sir.
Thank you very much. We are grateful to the legacy of Chief Dr. MAJEKODUNMI. He was at the forefront of those who established the Lagos University Teaching Hospital. May God's perpetual light always shine upon him. The past was so glorious that Saudi princes were coming to Nigeria for treatment. And many tropical textbooks on medicine were written from our hospitals, Luth, Ibadan, and all that. What went wrong? Years of misgovernance, zero budget growth, industrial disharmony, interdisciplinary rivalries, poor pay, poor investment in healthcare, and things like we couldn't transit from a welfare system to a capitalist system which we are running now. Nothing in life is free. We are still arguing for free health. Somebody must be paid down the line. We are not thinking of healthcare financing. I'm happy Mr. President has just signed the National Health Insurance Authority Act of 2021. We need to implement that thing very quickly so as to liberate the huge amount of money that is inherent in a well-run healthcare system. There will be enough money to take us home. Nobody needs to go anywhere. Our boys will come back when we can pay them commensurately to the amount of kind of work they are doing. These are my personal thoughts. Anybody who invests in healthcare almost till date is hugely subsidizing the cost of that care is given for the client, because nobody can pay out of pocket for the established a first-class cancer center in Luth. It's the NSI Luth Cancer Center. You can get any kind of cancer care treatment you get anywhere in the world there. When done by Nigerians, conceptualized by us. And it's running, it's oversubscribed, it's doing well. But you cannot charge what would take that center home for the average Nigerian, because they won't be able to afford it. So while you are charging, you'll be charging about 1/5 of what people will charge in other clients for that. So what are the returns? They will be marginal. But if we unleash the National Health Insurance Act, and there is a pool of funds from where people are paid, nobody wants to go abroad. if you hear the real experience of those who have to, for one Sheikh Abudu, I'm very proud of you, Sheikh. Where is it? Sheikh, we are proud of you, and we must talk after this. For one Sheikh Abudu, there are hundreds that aspire to be, but who came out. So what I'm saying is the future is rosy. Let us talk properly about how we will finance healthcare, make it a veritable investor's destination. Let people invest in it. It will yield good money. Our boys will come home. Let us also make the country safe. There are people who want to practice in Ajakuta, who want to practice in Katsina, who want to practice in my village. But are the simple things of life available in those areas? Farmers cannot even plant and harvest their crops safely now in the hinterland. So once we make the country safe, we bring peace and prosperity to the land. Healthcare will thrive. Healthcare financing we must face properly. And I'm very happy that the future is rosy. I've spent 42 years in this country as a doctor. I still haven't found a reason why I should leave this country and go and practice elsewhere.
Thank you. Thank you very much, Mr. Chris. And of course, I can see our eminent chairman here. I'm sure in his remarks he'll have something to say about financing of healthcare, because clearly we haven't structurally got that right. We have all the right intentions on insurance and so on and so forth to make healthcare affordable, but somehow we haven't been able to get it to work well, unless, of course, in Ogun State, maybe Dr. Tommy Koka has the solution to providing universal health care for citizens of the state, and an example we can copy.
Thank you very much, Royal Highness. I'd like to acknowledge you and the distinguished guests in the audience. In Ogun State, it's interesting because I'll be one of those brain gains. I did leave after my youth service and worked in England for 28 years. But having been there and watching what was going on, I'm a consultant obstetrician and gynecologist. I couldn't stay in England any longer and watch our women. I saw the statistics. In England, the maternal mortality rate was 7 per 100,000, and in Nigeria it was 700 per 100,000. And I felt it's no more about income, but about, impact. So I was fortunate enough to get this job. And the first thing we realized that we had dilapidated infrastructure, aged equipment, and a dearth of healthcare workers. So we set out to address that, particularly at the primary health level. And we've been renovating and equipping, and the lecturer mentioned the social determinants of health. And for me, I've been a clinician all my life, but the role I actually sit in now is more of sort of strategic public health role. And it made me realize that the impact I made as a consultant is nothing compared to what the public health practitioners do. So you need things like water, light, right infrastructure to actually allow 70% of the people who live in the rural area. We are a minority in this room. We're the top 5%, most of us. And when you go into the hinterlands, they can't afford health. So we have to find a way of funding this. We've tried to address that by asking people to pay for their healthcare. The government has actually tried to do the Basic Healthcare Provision Fund, which is 1% of the consolidated revenue of Nigeria, but it's not enough. In Ogun State, what we got was able to actually register 63,000 people out of 7.1 million for free healthcare. It's not even up to 1% of the population. So we need to do more. People are not signing up for voluntary healthcare insurance. In England, where we have the NHS, which was where I practiced for 28 years before coming back, it was about 99% of people would pay their tax. So it was deducted straight from source. In Nigeria, there's only about 66% of us paying tax. So how can the government actually fund it? What we've managed to do in Ogun State, I discovered that people are willing to pay the little. In the primary healthcare centers, they'll pay their 500 naira, but the money wasn't going to the right place. We had drain of the income from the primary health centers. So what we did is we did cashless system, and we had a 600% increase in income from that. So right now, our primary health centers are employing doctors, fully paid 200,000 a month from the income that they generate, without recourse to the government. We're employing nurses. In the last 3 months, we've actually employed about 60 doctors. When I arrived, we only had the medical officers of health in our 20 local governments. And I looked at the high-performing primary health centers. Why don't people go to primary health centers? Because they never find doctors there. We insist that people have insurance. They get the insurance. Who sees them? They don't meet nurses. So from the funds from the insurance, from the basic healthcare provision, from income generated from the primary health center, we pulled it into a treasury account, which means nobody can touch it, and visibility from the central. So we've taken care of corruption at the primary health level so that healthcare can fund itself and people have access. Our pregnant women now get free treatment from the basic healthcare provision. If you're pregnant, you get registered for free. So I personally, from where I sit, I believe there's enough money in the system that can start to make the difference. When the lecturer actually presented, I looked at the graph, the mortality graph. The gradient between the 60s and the 80s is the same gradient when we had the Millennium Goals. There was a plateau in between. So what were they doing in the 60s and what did we do when the Millennium Goal happened? There was more focus. So we have enough policies, but we need to block the leakages and make more people, widen the tax net and make more people pay into that pot for health. I know there's the fizzy drink, the tax in the fizzy drinks now. There's another mobile phone tax coming in, and they're going to increase the basic healthcare funds to 2% of the consolidated revenue for the nation. Hopefully with this, we'll begin to make a difference in the healthcare system. Thank you.
Thank you for updating us on what's happening in Ogun State. Looks like there is an important step forward there. But back to you, Dr. Adesegun. What's Lagos doing about the future of healthcare? We know you've done a great job in controlling pandemics and preparing for epidemics of various sorts. But as the lecturer said, back to basics, because you cannot cope with the volume of people coming into Lagos State on a daily basis. How are you preparing for the future?
Okay, so I'd like to be very clear. Before now, you had asked me to talk about brain drain, brain gain. Should I now just go straight to what we're doing about the future of healthcare?
Well, I want to know also, I think we all want to know what you're doing about brain drain. Am I right?
Okay, so you see, the concept and the topic of brain drain and brain gain is something that I am very angry about. And this is also passing the concern that the Honorable Commissioner has. A bit of background. I come from a family of doctors. My uncle, who is my mentor, Sunday Omishakin, he's left Nigeria for a long time, and then he came back. And right after I was leaving medical school, he said, don't go anywhere, just stay here. He was in the UK for such a long time. Now, a couple of other people I know in their 50s and 60s always want to come back. I mean, I've spoken to friends who've left for 10, 15 years. The only song they sing is, Sunday, can we find something doing back in Nigeria? Let's set something up. Let's try to do something together. Also, Lagos is the last bus stop before people leave, if you know what I mean. I mean, with the population we have in Lagos, we have massive general hospitals, 28 of them, employed over 2,000 doctors. And all of our primary health centers, 77 of them are comprehensive. They're on 24-hour shifts. They have at least 2 to 5 doctors in each of them. So we employ a lot of them. They collect salary for 6 months and leave thereafter. The unfortunate thing, however, is that they leave gaps. You know, the moment they just tell you 2 days before they leave, MD, I'm sorry, I have to leave in the next 2 days. And then the MD is stuck between either sending you with a curse or a blessing. It's the truth, because you put the pressure on the other people who are left behind. What we have done, or what we are doing, is that first, we're making it a little more comfortable to stay in Lagos. So every new concept or every new general hospital we're building is coming with a staff quarters. So the one in Ojo, for instance, has staff quarters. And all of it is not just financed by Lagos. We have gotten commitment from donors. Chevron actually. Chevron is building staff quarters in Bagada General Hospital. Bagada is one of our largest general hospitals. So it's going to have staff quarters, and more people have more reasons to stay. I mean, the moment you have a place for you to live and you're not exactly paying a lot for it, you probably would like to stay. The other thing is to make sure that there's a future to look at, you know. So we've made it much easier for you to transit into residency. So if you know that, if a doctor, for instance, knows that he's going to get into training and become a specialist thereafter, he's more likely to stay. The third thing is wages. So among state governments, I think Lagos pays the highest. So we pay a lot more than the average state government does. We've increased allowances because we know, again, that it's more expensive to live in Lagos than in most other parts of Nigeria.
Sorry, I mean, I don't think it should be a secret what doctors earn. So maybe you could tell us.
Okay. So it gets more interesting. I think before I tell you exactly how much it is, it's also important to mention that there is nowhere in Nigeria where you will match what a doctor earns in the UK. And that is because by the time you do your conversion, there's that mismatch and imbalance. Also, it's important to state that, Lagos pays, Lagos pays significantly well. The average doctor, right out of school, right out of NYSC, getting employed in the state government, went about 250,000 naira. Yes, I hear at the back, but I know it's not a lot of money, but it is decent.
No, we're not judging. I don't think we're being judgmental, but we do need to know what we're talking about to put it into perspective. So it's nice to know that that's how you start. And obviously, that does propel those who are looking for improved education and living to want to go abroad. So
absolutely.
Just put it into perspective.
So it's also important to mention, I mean, while we're talking about what to do or what we're doing, Lagos is beginning to look at making sure that we're producing more doctors, more nurses, more radiographers. So one big problem we have in Nigeria is the healthcare workers or healthcare workforce, as it were. We've seen the comparison. We're down on that chart. And I think that on the federal level, we need to devolve the approvals you need to train doctors, nurses, radiographers, and all of those people. I make bold to say that radiographers in Lagos now are they are earning more than doctors because their transit to the UK is shorter, it's easier. They just need to write IELTS and they are gone. So you want to employ a radiographer, is asking you for 350,000, 400,000. They don't even stay. You employ them for 6 months, they're out. So what state government, and Lagos is taking the lead, are trying to do now is to make sure that we can have licenses to train all of these people. In London, for instance, you have more than 14 general hospitals and medical schools attached to the University of London. In Lagos, we have 28 general hospitals. We have abundance of patients, and then we have 2 teaching hospitals. Lagos, with our population of 23 million, can accommodate at least 13 more private medical schools. And people are willing to pay. You rather pay to study in Lagos than send your kid to Ukraine or Russia to study medicine.
Yeah, thank you. Thanks. But I will add something to that about Ukraine because I have some direct knowledge about that. That the medical students who went to study in Ukraine surprisingly weren't allowed to practice clinical medicine. They weren't seeing patients.
Yeah.
So they were just getting a lot of theory, which is very sad, and it didn't come to light until the war in Ukraine meant that a lot of them had to leave. So it's not all that rosy going abroad, especially when you're paying for it. In any case, given the cost of airfares and the absence of Emirates, maybe no one will be able to go anywhere anymore. But Prof, Professor Bode, in terms of in the educational sphere, the lecturer also spoke about the importance of statistics and having a dedicated center for collection of data and study of health outcomes. Isn't that a wonderful way that Luth perhaps could start up? And because I think we all agree that it's important to have data and to see how that data is affecting the planning for healthcare. And I just wondered whether, in fact, there is something going on that we don't know about, or it's something that we can look into.
Thank you. It's been, the story had been over time. There were islands. Each institution kept their own data for their own consumption. But gradually, with the introduction of hospital information management systems, we're beginning to see things that are common from between institutions, establishments, and all that. And furthermore, there is a Department of Statistics and Planning at the Federal Ministry of Health now, which now requires for us all to be submitting data to them periodically. And when each hospital develops its own hospital information management system, they hook onto that, and at a glance, the ministry is now able to see quite a number of things, trends, disease patterns, all sorts of things, which, because we are encouraged to use a uniform template for those reporting. So it's a good thing. For example, the ministries recently asked all tumor bulbs in each hospital to submit a uniform template, their report through a uniform template to the ministry. So it's an evolving thing. We will eventually get there with the increased utilization of IT, which we've been forced to do now. I would say thanks to COVID, well, that's partly part of it. So it's a desirable thing that Professor Abudu has suggested. It is in the works, but we need time to integrate it nationally. It is being coordinated by the planning department in statistics of the Federal Ministry of Health.
At least something is happening. So Professor Abudu, they're working on your suggestion. Finally, back to Ogun State, because I think it's important to know what two of the foremost states and two of the most populated states in terms of the pressure of population in the south are doing. Primary healthcare, water. It is true, and I don't think anyone in Lagos would dispute it, that if you want water now, you're going to have to either buy it or have a borehole, and if the state is struggling to provide clean water, how have you been able to tackle that in Ogun State? Because it would be a way of helping with primary health care.
Thank you for that question. As I mentioned earlier on, we've been renovating our primary health centers, and we always make sure we leave a borehole. And the vision when primary health center was started is that it would be the center of the community, so that the people in that locality, they have source of clean water from the primary health center. It's also, we also put solar lights or generators so that the people in that community have access to light when they're there. So for us, it's simple. You renovate, you put a borehole. Water hasn't been an issue for us. The only primary health centers that won't have water in Ogun State now would be ones that we haven't actually got, because that's the primary for healthcare. It's very important. even for infection control within the health workers. So that hasn't been an issue. I'd like to contribute a little bit to what the two previous speakers spoke about the brain drain. I think there has to be something you call joy at work. The speaker spoke about culture. We have to actually value ourselves. What I find is people don't value, they're not proud of what they do. It's not all about money. I know it's money answers all things, but you have to take pride in what you do and know that medicine, the healthcare, is a calling. And we have to do it with pride. You have to make your patients feel good, even when you don't have anything to treat them with. The way you treat them, your manner towards them, makes them feel good. And you, in turn, can go home and feel, I've done something well today. We need to review the structure. I think 3 groups of workers in Nigeria that their wages should be reviewed are doctors, the security agents, and teachers, because without teachers, you cannot have doctors and all that professions. So we really need to look at that. And he touched on providing them accommodation. Also soft loans like car loans, fixing, Innocent, go to Innocent, and as the government, we can just say for their cars at X amount, and making sure that the children have good schools to go to, which, a lot of people, parents who taught in the university, they went to staff schools. They are the doctors and lawyers today. They're the middle class. We need to go back and address those things, and people would stay. Lastly, Nigeria needs to start charging those countries that come and take our professionals. We do. It costs £500,000 to train a doctor. And they come and take doctors that have been trained that they haven't invested in. The government has to charge them and then use that money to train more doctors, healthcare workers. We build university, pay our lecturers well, and improve our healthcare. Thank you.
Well, maybe I shouldn't be defending the British, but they're only asking if you'll come over. We are volunteering to go. But perhaps it is something to think about. Quite possibly, a way in the future is to provide the standard of education here that people from the developed countries would come because they can gain experience and they would pay to be here. That might be what it is. But even when we don't have enough medical facilities for ourselves in terms of teaching, we've got a long way to go. I wish we could have a much longer conversation. There is a lot we could have talked about, but the time is run past when we should have stopped. And I know there is, in the afternoon, some more work for the medical professionals. So on behalf of everyone here, I'd like to thank Dr. Tunde Ajayi, who represented his boss extremely well, Dr. Tomi Coker, who we're grateful wasn't called back to Ogun State, and Professor Chris Bode, who represented both the Honorable Minister of Health and the Chief Medical Director of Ruth extremely well. Ladies and gentlemen, thank you very much. Your Royal Highness, distinguished ladies and gentlemen, the morning has turned to afternoon and it's been very well spent. 10th anniversary of a very important and famous Nigerian and a legacy which we will continue to honor. Our conversation today about Nigerian healthcare system is one that all Nigerians are having. And in fact, our contribution, we hope, is, even if it's a little small because of time, is something that will be heard. But I do have the opportunity to have someone speak in his closing remarks about the importance of the economics around healthcare. I know I think he'll be itching to do so because he has such a wealth of experience in this area. May I ask you all to encourage him to say a few words? His Royal Highness Mohammed Sanusi II, Commander, Order of Niger, to make a few closing remarks. Thank you, sir.
Thanks, Inkas. You know, it's always dangerous to encourage me to speak.
A member of this family.
I did say I would defer my comments until after I listened to the professor and the panel. And I'll start on a personal note. I'm going to tell you a story, and you know, this is a very, very small world. I got married for the first time in 1988. And usually when we get married, in my family, you've got a whole large number of princesses that get married. So there were about 8 weddings at the same time. And after my marriage, for the first 2 years, we didn't have a child, into the 3rd year, by which time each of the other 7 sisters and cousins of my wives had 1, maybe even 2 children. And it became a problem. Imagine, so just 3 years, and they were worried. So she was worried, and my neighbor said to me, go and see my gynecologist, who's a professor at LUF and who had a clinic in Yaba. No, went there, he did the tests. Anyway, through his help, we got my first child, who's now a DSP in the police force. Now, it happened that that gynecologist's name was Professor Abudu. So I asked this gentleman, are you related to Professor Abudu? He said, he's my brother. So if you see him, do tell him that the boy that he helped bring is now a DSP in the police. And is just completing a master's in counterterrorism studies at Leicester. So, I mean, you know, it's amazing, you know, that you just run into, it's such a small world. Okay, so I'd like to make 3 broad comments. The first comment is, I think as a people, and especially as governments, we have lost our respect for the professions that should be respected. Recently, I was in a WhatsApp group, and people were going about about ASU, about how these lecturers think so much of themselves and all that. And I tried to explain to them that I started my life as an academic. Teachers are not looking for money. Doctors are not looking for money. Generally, I mean, the amount of money we invest training our children to be doctors, they would never earn it in salaries in this country. But people deserve a decent life, and they deserve respect. You can't treat your teachers as if they're nothing. You can't treat your doctors as if they're nothing. I know I have a daughter who's doing applied medical sciences. After this, she wants to go to medical school. That's 7 years. I know how much I'm spending. Then for somebody to wake up one day, some politician, to abuse her, you know, I would be the last person to encourage a child to stay abroad. But before we talk about money, why don't we talk about respect? Do we respect educators? Do we respect teachers? Do we respect our doctors? And politicians need to set the stage in this. If you show that these professions are not important, well, people have options. They walk out. And they go. And many of them go not because, some people go because, look, you've got a hospital, they want equipment, some politicians refuse to give all the money has been provided, the budget has been stolen, and they can't work. And they want to serve, and they're not given the chance to serve. So before we go to the economics of it, shall we perhaps begin to go back? I mean, when we're children, your primary school teacher, your headmaster was one of the most highly respected members of the society. We don't respect that profession. And education and health are the foundation of development. If you lose that, you're finished. Now, let's go to the macro. We talk about people having a right to earn a decent living. And I think, you know, I keep saying this is one of the few countries where people just don't care about the economy. They don't understand it, or they think it's not important. The first time I saw in 2016, I think, inflation figures of 18%. They were announced, the figures were printed. In this country, it was like, oh, it rained yesterday. 18% inflation means the price of everything on the average doubles every 4 years. And that's what we've had. A bag of rice that was 8,000 naira in 2015 is 35,000 naira now, 4 times in 8 years. By how much are doctors' salaries increasing? By how much are teachers' salaries increasing? I mean, people want to serve, but they want to eat. They want to educate their children. They're human beings, they have basic responsibility. We've created an economy where everybody who is on a naira salary is getting impoverished. And we are not having that conversation. We're saying, "Emi loco." We are not having that conversation. And these are the conversations we need to have. We are still talking, she president from the north or the south, Muslim. Is that really the problem? And we've just gone through, I don't want to say 8 years, let me just say 12 years, so I'm not targeting any particular person. Okay, decades, okay, of digging ourselves into holes. And we are on the brink of national collapse, and we are not talking about these issues. In this hall, in 2011, we had a debate over fuel subsidies. There was nothing we didn't do to tell Nigerians, what are your priorities? What are we hearing today? We're going to spend 6.7 trillion naira on fuel subsidy. I mean, we're being told this is a problem, but we are going to continue paying until June next year. The next government comes in, it says it can't remove subsidy because it has just come in. We'll continue. We've bankrupted the state. But let's even forget the bankruptcy. What are we really saying? You spend 6.7 trillion on fuel subsidy. That is 6.7 trillion out of education. 6.7 trillion out of healthcare. We're saying that cheap fuel is more important to us as a country than the education of our children and the healthcare for our wives. That is all we've said. Meanwhile, this cheap fuel is not coming from government savings. We are borrowing to consume cheap fuel, which will be paid for by our children and our grandchildren. The same children and grandchildren we are not educating are going to pay the debts that we're piling up for them, so we can have cheap fuel, which we import from European refineries, employing European workers with our foreign exchange. Is this a country? Is this a country? So, I mean, you can deal with the health care system or education in isolation, but the bottom line is that our economy is being run into the ground, and we are not speaking, we are not conscious, we're not aware. Everyone is in a small corner. So long as you're earning your salary, your children are educated, you don't care. You don't care that people are paying 4 times the price of rice that they were paying 8 years ago? Well, you know what? It's coming back to us. Today, your child is abroad. You have your naira, you're ready to pay black market rate. You're lucky to find the forex that you can transfer to pay school fees. With the money, with your own money. So we can't understand these problems, whether it's healthcare or education or security. We can't treat them in isolation of the macro. And we have to talk about it. And politicians are not happy, but yeah, it's not my business to make you happy. We have to talk about it. And I don't think we're going to get a solution until we get that right, until we begin to understand that inflation, exchange rate, the fiscal problem, these things have an impact. If you're spending your money foolishly, if you're earning little, and you decide that what is your priority is cheap petrol that is not produced by your refineries. I mean, you talk about brain drain, this is our whole economy being drained and taken to what? Refineries in Europe, which smiling away. So the problem is global, and I'm not saying it is that this is not a problem. I'm saying that you can't address this in isolation. The final point I would like to make is, the issue of concept. I mean, you look at Lagos, you look at Ogun, you look at Ondo, when we started cashless Nigeria, I remember the governor of Ondo State at that time, I think it was Mimiko, was one of the first to catch on, to use the mobile banking, for women maternity. At that time, half of the country was abusing me, and what was their concern? That we're putting a fine on people who had large cash transactions. It was not the benefits, not the advantage of technology, which we are now all benefiting from with our ATMs and POSs and all that. People were concerned that it was going to restrict money laundering. It was making money laundering more expensive. That is the reality. Why can we not take cash? Why can't we take millions in cash? Why are you punishing us for that? But technology today underpins everything. I mean, the doctors now, I was just telling my brother here, I've got this acid reflux. I mean, you go to an ENT specialist and he's showing you your throat. It's a horrible sight, but but I mean, without the advances in science and technology, we wouldn't get where we are. We're not investing in science. We're not investing in technology. What are our priorities? So the states that have it right